So when we look at, obviously, everybody wants to know what's going on in the world with COVID and obviously how it relates to us specifically in the Parkinson's community. So Dr. Veerapan, welcome. Thank you for taking time out of your busy schedule to be here with us. I'm going to turn things over to you, and I'm going to mute as well so I can monitor the chat and make sure we get everybody in.
Well, I'd just like to introduce myself. I'm glad to be part of the GAPS program and having the opportunity to speak. As Laren had mentioned, I'm a recent member of the PRISMA neuroscience group, and I'm part of the clinical teaching faculty here at our new neurology residency program in Greer. So I'm excited to be here. I'm excited to talk about Parkinson's disease, COVID-19 vaccine. As Laren had mentioned, I've gotten several questions already, so those are kind of incorporated in the presentation. I have a section towards the end on frequently asked questions. So hopefully it should cover kind of the breadth of at least the information that's available on the COVID-19 vaccine at this point, and as it relates to Parkinson's disease. And just for my background, so I just started in PRISMA last September. Prior to that, I did a 2-year movement fellowship at OHSU in Portland, Oregon, and at the Portland VA, and then did my residency training not too far from here in Chapel Hill, North Carolina. So excited to be here. So I'll go ahead and get started here. But before we get started, I kind of wanted to just do a historical review, just kind of on pandemics in general, and how they've really affected society throughout the years. And I thought it'd be just kind of a neat way to just kind of bring things into perspective. And really, this illustration here on the right is really the coronavirus, corona meaning crown. So you can kind of see how you might get that image from this really high resolution picture of the virus here. So to kind of really put things into perspective, pandemics have really been around for as long as humans have really been alive and have documented such things. This is kind of a timeline that I found that really illustrates how long pandemics have been around and how severe they've really impacted society. So you can see here, and actually before we even talk about that, pandemic really comes from the Greek root, really meaning it's really specific to a disease that's really prevalent over a whole country or the whole world. And you can see as far back as even 165, 180 AD, that there was a documented plague, the Antonin Plague. And if you kind of work your way down the timeline, the biggest and probably most well-known in history is really the Bubonic Plague or Black Death in the 14th century. And these illustrations here, kind of the bigger they are, really signify the kind of death toll and impact they really had on society and how much it really affected everybody. And it's been there ever since then, the 14th century, 15th, 16th century. You can see they kind of didn't even give it specific names. They just entitled it Great Plagues of the 17th and 18th century. And I'd like to highlight this one here, actually, the small one here, the cholera outbreak. So this was really one of the first instances of where we started relying on looking at geography and statistical analysis. So in 1854, Dr. John Snow actually was looking at a cohort of folks that all developed cholera, kind of saw where they were living, and really isolated it to the fact that they were all centered around a specific water pump that was thought to be tainted, and actually it was a source of the cholera virus. So that's kind of where a lot of the epidemiology, contact tracing, all of these things really kind of stemmed from. And as we kind of move forward in time, you can see probably one of the biggest ones that's really talked about in the news, kind of comparing it to present day times, is kind of the Spanish flu in the 1918, 1919, and then so forth. The more recent times, things that people are probably more aware of, the HIV AIDS pandemic, which is still present, but is curtailed to a large degree due to the advancement of antiretroviral therapies. And the ones really kind of in the most recent last 15, 20 years, the SARS virus, swine flu, the Middle Eastern respiratory virus, Ebola, and then the COVID-19 here. So a couple of interesting things that I'd like to just point out. So in March 11th was really of 2020 was when the WHO declared the coronavirus a pandemic. So we're really almost coming up on the 1-year anniversary of when it was declared officially a pandemic. And a lot of things we've learned from history as well, too. So interestingly, at the time of the Black Plague in the 14th century, there was thought that the virus traveled on potentially the ships and on actually using the rats that were transmitting the disease, actually. So along all the coastal cities, the authorities at that point actually had the ships just that transported goods and so forth, actually have them set anchor offshore, had them stay there for 40 days. And only after that period of time would they allow the ships to kind of disembark and the goods to be brought onto land. And that's actually where the term quarantine actually even comes from. It's actually from the Italian word quaranta giorni, which actually means 40 days. So a lot of these things, a lot of the terminology that we're even using nowadays actually comes from all these things in history here. And so here, I just wanted to just highlight kind of the impact it's had on society. As you can see here, these are estimates in terms of how much it affected the population in terms of death toll and mortality here. So the biggest with the Black Plague, 200 million. It took almost Europe 200 years to actually recover from this from a population standpoint. Smallpox largely affected Europe and significantly affected the Native American population here, killing almost 90% of the population of Native Americans. It was the first entity for which a vaccine was developed and essentially has been eradicated at this point in time. And you can see here, Spanish flu, which actually the Spanish flu, interestingly enough, is actually a misnomer. So this disease pandemic occurred in the setting of World War I. So I'd like to point out actually even at that point how much of an influence the media had. So both sides of the war didn't actually want to report on the number of patients and casualties that had the disease. And the one country that did report it at that point early on was Spain, and they were a neutral country, so they were free to report it. Even their king had developed it, and so they reported it. And since with the media not reporting it from the other sides, they kind of dubbed it the Spanish flu, and that's how that terminology has really persisted ever since in society. And interestingly enough, one of the earliest cases was actually even identified here in the US. So again, a little bit of a misnomer, but you can see kind of even back then how much a role the media has to play in everything here. But the latest estimates here for COVID-19, this data is as up to date as of February of this year. We're at 2.2 million cases, and this is continuing to rise and probably at a higher number at this point in time. So here, the next few images are really going to compare and contrast kind of how things were back then versus now. The image on the left is kind of what we think of as the doctor who practiced treating patients with the bubonic plague at that point in time. So you can see some of the things even early on there, the wearing of a mask with kind of even goggles here, wearing a full leather gown or tunic here to really prevent kind of transmission of disease. And they used a wand here to really tell, because they didn't want to come in contact with the patient, so they'll use a wand to direct the patient on what to do. So even then, there are some aspects of social distancing even back then. And interestingly enough, with the mask, back then they used to think that it used to be transmitted through bad odor or melasma, which now is proven to be not true, but they would actually house spices and herbs like juniper berries and mint and roses to really ward off the stench in these beaks at that point. Design, interestingly enough, was designed by the physician for King Louis XIII of France. So that was the Black Death or bubonic plague, so kind of the attire for the physicians then. This one on the right is kind of more of an illustration from an artist, so kind of taking things kind of into more of a comedic effect. But you can see here, even then wearing a kind of a facial mask, a pot of steaming water to ward off things, cigar with smoke to ward off things, a shoe with stones underneath to maybe trample on the virus and different things like that. So it's kind of interesting things even back then, and kind of compare and contrast to now. Now surgical masks, we're wearing gowns, N95 masks, face shields, and even PAPRs, which are the powered air purified respirators here. So a lot of things similar to before, but advancement in technologies. So this illustration then comes from the Spanish flu. You can see here, this illustration is entitled Influenza Rush on a Germicide Station. So you can see here how everyone, once they have identified that germicides help prevent transmission of the disease, how everyone's kind of descending on this one station. And that kind of compares to 2020 here, where I found these interesting pictures from kind of Costco, where everyone was kind of rushing to kind of buy the necessary goods that they thought would help in the setting of a pandemic. And this picture on the right, kind of common household goods, paper towels, toilet paper, Clorox, Lysol, things of that nature. So really in 100 years, things to me have not changed dramatically. Another compare and contrast image here on the left is kind of an Army field station emergency trying to treat patients that had the influenza, the Spanish flu at that time. Here, an everyday receptionist working while wearing a mask. Again, 100 years later, almost exactly the same thing. Emergency Army Field Hospital that was set up here early for overflow capacity from hospitals. And a similar illustration of a worker at this point in time wearing a mask. And then just a couple other images here. So a policeman here wearing a gauze mask. So even at that point in time, 100 years ago, different types of material for wearing masks, and an entire Army regiment here wearing a mask. So why do we wear masks? So I think this illustration that I found kind of puts things really into perspective here. So this breaks it down into the different types of particles and the size of each particle. So just for a comparison's sake, this illustration here is actually a human hair. So the size of that, 50 to about 180 micrometers or microns. And then as you kind of work your way down, the things that you think of as very small, like sand or a grain of salt, blood cell, pollen, and so forth. The things that I would highlight here are the respiratory droplets, 5 to 10 microns, micrometers. And then down here, coronavirus, 0.1 to 0.5 microns in diameter. So really much smaller. So the real goal of masks is to reduce the transmission of these particularly respiratory droplets, which really aerosolize the virus and cause transmission. So wearing a mask is important to reduce that. And down here, the N95 mask for healthcare providers really gets it down to the name N95 actually stems from the fact that it's 95% efficacy for reducing transmission of particles down to 0.1 microns. So the importance of mask wearing is really to prevent the transmission of these two things. And you can see how small they are in comparison to kind of even everyday objects that you might see. So the question comes, and I'll kind of delve into it a little bit more later, the types of masks and what to wear. So really, any kind of mask is better than no mask. And the specific type of mask really to wear is something that is form-fitting, something that's not going to have any air leaks. So if you have a surgical mask with kind of a nose bridge that really clamps down on it and seals on the sides, that's important. Or a cloth mask that seals everything in is important. Some cloth masks aren't as good as others. So the ones that the CDC recommends are really ones that are tightly woven, 2 to 3 layers that really don't transmit light. So if you flash it, if you turn on a flashlight, you shine it at the mask, really the transmission of light should not go through it. That's kind of an arbitrary marker that some people use. So some of the other cloth masks that are very loose, they may not be as effective as something that has multiple layers, is tightly woven. And recently in the news, this was a question that came up from somebody that had sent it in. Do we recommend double masking? And I'll talk about it later again as well too. Really, a single mask that's form-fitting, no air leaks is ideal. Some people wear the surgical mask and sometimes it doesn't have a good seal. So on top of that, if you wear a cloth mask that really seals everything around the edges, then that's good. But double masking is not necessarily necessary as long as the first mask is, as I said, form-fitting. Things that aren't recommended are things like bandanas, gaiters, because the bottoms can be open, so that can still allow transmission of respiratory droplets and virus. Masks that have a vent on it are also not recommended. So again, tight form-fitting masks are ideal. So COVID-19 in South Carolina. So the IHME follows metrics for all different states and cities and countries all around the world. This is maybe a week old, but this is kind of the latest daily infection and testing rate for South Carolina. So you can see here the peaks. At the time of the initial onset of the pandemic, a smaller peak. In the summer, there was a hike in July and August. And really the post-holiday peak was probably the thing that really came. We were kind of on emergency status here at Prisma, was kind of the highest in terms of daily infections and testing. And that's kind of really trended downwards, as you probably have heard in the news. And I checked yesterday, this continues to trend downwards. So things are on the improved trail. Again, the vaccines really started kind of tail end of December and are kind of gaining more steam in terms of the number of patients that are and population that's being vaccinated. So that's maybe playing a role. Maybe less holiday travel is playing a role in this downward trend, but things are headed in the right direction. In terms of daily deaths for South Carolina, again, multiple peaks. You can see here early on, April, May, big peak 15 deaths almost a day from COVID-19, then heightened up to almost 50 plus 55 in the late summer. And then with the holiday season, again, big peaks. Again, this is also on the downward trend. So things, again, seem to be heading in the right direction. But as you can see, there was downward trends in the past, but then followed by spikes. So there's a lot of things that play a role into this, but this is kind of just the most up-to-date data for South Carolina. So I'd like to transition now over to kind of what's more relevant for us, really COVID-19 and Parkinson's disease. So a caveat that I would say is a lot of the data very early on, a lot of it is kind of more retrospective, chart reviews, patient surveys, and things of that nature. So one of the big questions that I've received is really, are patients with Parkinson's more likely to get either COVID-19, be hospitalized with COVID-19, or have severe cases of COVID-19? So this is probably one of the biggest population-based studies that was published thus far. This was a study out of the Italian group in Bologna. The first case was identified in Italy, actually, pretty early on in February. So they really compared patients in a specific area of Italy. So they looked at around 700 patients with Parkinson's disease, 200 patients with Parkinsonism or atypical Parkinsonism, and about 8,500 control patients. So what they looked at was really their admission rates. So what led them to the hospital, and was there an increased tendency for patients with Parkinson's to be hospitalized? So the rates actually for Parkinson's disease and just the general population were actually very comparable. It was about 0.6% in folks that had Parkinson's disease that were hospitalized versus 0.7% for patients in the general population that ended up being hospitalized. The patients that had Parkinsonism or atypical Parkinsonism, there was a slightly higher rate, about 3.3%. So there's about a threefold increase in patients that have Parkinsonism. And that may stem from the fact that some of those patients with the atypical forms of Parkinsonism may have more disability and have more symptoms and things of that nature. So really, the takeaway is that Parkinson's disease per se is not a risk factor for COVID-19 hospitalization, but it can be an independent risk factor because folks that have Parkinson's disease may have other illnesses as well, and they may have a more severe health status. And then again, patients that have Parkinson's disease tend to be older, which again is another independent kind of risk factor. The risk factors really across the board are things like age, so the older age, a history of a stroke, a history of a heart attack, heart failure, diabetes, kidney disease, cancer, and heart failure. So all of these things, as you might imagine, folks with any of those illnesses tend to have other medical issues and again, may have more disabilities, and those are risk factors for being hospitalized. So really, Parkinson's disease, just by having it doesn't mean you're going to be hospitalized more or anything like that, but it's something to pay attention to. And some of the recent studies looking at it, again, very, very small studies, so the sampling data is very, very limited. But some studies in the patients that ended up being hospitalized with Parkinson's disease, there was a small study out of a Parkinson's Foundation, a program in Iowa, that maybe there was an increased risk of mortality or death in the patients with Parkinson's that ended up hospitalized. Again, the numbers span quite a range. And this recent study, maybe about 30% of patients. So patients that did end up getting hospitalized with Parkinson's, there is a little bit of a higher mortality rate there. But again, the data is pretty limited given the studies. In terms of how it affects Parkinson's disease, so there's been a couple of studies. The most, probably the most succinct one was from a group out of Italy, again, Roberto Cilia's group. It looked at really motor performance and also non-motor symptoms. So folks that had Parkinson's disease that went on to have COVID-19, there seemed to be an increase in their motor symptomatology. So motor symptoms, tremor, stiffness, slowness of movement, those things seem to get worse. And kind of as a corollary to that, the medications may have to be adjusted to help with their motor symptoms while they had COVID-19. So that seems to be a trend. So patients that had Parkinson's that went on to develop COVID-19, there was an increase in their motor symptoms, and their medications may have to be adjusted as well. And maybe about up to a third of cases is what was reported. Additionally, non-motor symptoms, so anxiety, depression, fatigue, changes in urination, all these other things, there seemed to be also a tendency to be increased in those things, as you might imagine as well too. So again, with COVID-19 and Parkinson's, there does seem to be an increase in non-motor and motor symptoms if you did develop COVID-19. A lot of studies coming out from all across the globe here, the impact of COVID-19 and social distancing, the impact of COVID-19 and quality of life in patients with Parkinson's, how it affects neuropsychiatric symptoms. So as you might imagine, a lot of the goals of Parkinson's disease treatment and therapy before the pandemic was to be actively involved in exercise programs and rock steady boxing and physical therapy and being out and about in community setting and patient support programs and all those things. And so with the pandemic, social distancing, limiting encounters with others, as you might expect, there tends to be a rise in social isolation, feelings of depression, feelings of anxiety. So these are the kind of the big findings. There tends to be an increase in these neuropsychiatric symptoms. It has affected quality of life because folks were used to going out to go to their exercise programs or different things like that. So, but we've done well in translating over into one from a healthcare perspective, meaning telehealth. So a lot of the providers are doing telehealth, which has been very, very helpful for a lot of folks. Don't have to travel, limits their time to come to clinic and all those things. So that's been a good boon, I would say. I would also say that the exercise programs have also equally adjusted as well, with everything going virtual. And I think that's been a big advantage as well too. So people are able to exercise from the comforts of their home in a safe environment. So we've adapted, and I think that's important. But something to pay attention to is that non-motor symptoms can be impacted. So if you see your provider, make sure you mention these things, that whether you're feeling your mood is a little lower or anxiety might be a little bit more. These are definitely things that can play a role, and I think something that should be carefully looked at. Again, all of these are survey studies, and some of them are, again, like I said, are retrospective studies. And I would say big kudos to all these groups that have published data on Parkinson's disease and all these related things. It's not hard. It's not easy, I would say, to perform research in the setting of a pandemic. So it's really a big effort. I really praise these groups for publishing these data, and it's helpful. But there still remains a lot of data that's going to come out in the near future, and we'll learn more and more about how Parkinson's disease is affected by COVID-19. So I'd like to just shift over to kind of the crux of the talk today, really about the vaccines. So these were the two that I had prepared for, and then last night the Johnson & Johnson one got they published at least their preliminary findings and submitted their data to the FDA. So I'll highlight that briefly, but I like to highlight the things that most folks are at least hearing about in the news, which are the two vaccines, the Pfizer component or BioNTech, and then the Moderna. So both of these are mRNA vaccines, and we'll delve into that. These are both currently approved. They're currently approved for 2 doses. So really, how do they work? So there's 2 components to the vaccine. There's the nanolipid coat, which really protects the mRNA against breakdown and allows for the cells to really take it up. And then the mRNA, which delivers the information to the cell. And so what the mRNA does is it carries instructions. It carries instructions for what we call the spike protein, these things on the outer surface of the virus. You can kind of think of it as kind of either quills on a porcupine or, kind of like those rubber balls that, the dogs like to play around with, kind of those things. And so once you get the vaccine, the mRNA gets taken up by some of the host cells. Then the mRNA tells the host cells to display these spike proteins on those cells, and then that'll trigger an immune reaction in your body to develop antibodies to the coronavirus. And those antibodies are important to fight off future infections. So basically, if you were to develop an infection down the road, you already will have antibodies that will help fight off the coronavirus. And the mRNA doesn't go into the nucleus of the cells. It doesn't affect your genetic material, and it's not a live virus. So it's a new technology, but it's been out for many, many years, but this is the first time it's really been rolled out on a large scale for vaccines. So it's very, it's a technology that's been out, but it very, very effective. And we'll talk about the efficacy here in a little bit. So what the Pfizer vaccine was looking at was really the number of COVID-19 cases occurring after 7 days after the second dose. And the Moderna, what that one looked at was the number of COVID-19 cases after 14 days of the second vaccine dose. So there's some things that I would like to point out here. So the people that were enrolled in the study kind of spanned folks that had COVID-19, then recovered from it, and it included the general population, variety of different risk factors, but they did exclude certain people from the studies. So people that were on either immunosuppressive therapy, so things that would bring down their immune system, or severe adverse reactions to other vaccines in the past, meaning like anaphylaxis, meaning trouble breathing, pregnancy, breastfeeding, come up some other exclusion criteria here. But they enrolled kind of the general population, so it's very generalizable to kind of everybody in the community, that they found that the efficacy rate was stable across, regardless of your age, regardless of sex, male or female, regardless of ethnicity, and regardless of high-risk groups, so folks that had cardiac disease or renal disease or liver disease. It was effective across all these different groups, okay? So here's the data. The data was so good that one of the articles I looked at kind of printed or put this picture in, and it's just kind of an interesting way to put it, because this is actually how the real graphs almost look like when they compared placebo groups versus the people that actually got the vaccines, and the number of COVID cases in the placebo group versus the vaccine group. It was a big difference. So the trial for the Pfizer vaccine they enrolled about almost 40,000 people, but some people were excluded because of various different exclusion criteria, kind of dropped down to 36,000, split into two, 18,000 placebo, 18,000 got the vaccine, 95% efficacy rate. So in the 18,000 patients that did get the vaccine, there was only 8 cases of patients that developed COVID-19 after their second dose of vaccine. So highly effective, 95%. The Moderna, 28,000 split into two equal groups, 14,000 in each group. Again, highly effective, only 11 cases of COVID-19 in the patients that got the vaccine. And again, remember, if I go back here, they're looking at cases of COVID-19 after 7 days of the second dose and 14 days of the second dose of Moderna. And what they're looking at is, yes, one is development of COVID-19, but the other thing is also the risk of developing severe COVID-19 or hospitalizations. So this is a thing that I'd like to just talk about a little bit in more detail. So what do they mean by severe COVID-19? So something that essentially is affecting your respiratory rate, your heart rate, breathing status, requiring oxygen, and leading you essentially to be hospitalized, go to the emergency room, hospitalized, potentially requiring an ICU admission, or even being on a ventilator. So the severe hospitalizations are the thing that it reduced significantly. So getting the vaccine reduces the risk of the severe COVID-19 hospitalization and even getting COVID-19, but there's still a chance of getting, what we characterize as either asymptomatic COVID-19 or mild cases of COVID-19. So it doesn't reduce that 100%. So that's something that you should take away from it, that the severe cases are significantly reduced, hospitalization rates significantly reduced. And that's the important thing, because that's the thing that causes mortality and morbidity. So again, both vaccines are given in 2 doses. There was some data to suggest that even after the first dose, that within 10 to 14 days of either dose, that there was definitely production of antibodies and help fighting off the coronavirus. But it's not as efficacious as getting both doses. The both doses is kind of what brings you up to the 95%, 94% threshold. So that's the importance of both vaccines. So this kind of compares and contrasts a little bit to the recent vaccine, the Johnson & Johnson one that was just talked about in the news yesterday. So that study was done all across the United States, South Africa, and various other, and South America. So it looks at all different types of actually even coronavirus 19 variants and mutations. So that the early data suggests that it was 66% effective overall in preventing moderate to severe COVID-19, 28 days after vaccination. And that kind of gets broken down into different continents. And for the United States, it was about a 72% reduction. So it's effective. It's a single shot. So it's a little different than the 2 shots for the Pfizer vaccine and the Moderna vaccine. There is some data to suggest that it also significantly reduces asymptomatic transmission of coronavirus. And there's also data for the Johnson & Johnson one to suggest that it reduces the risk of developing one of the variants of coronavirus, the South African variant, because the study was done in South Africa, whereas these other 2 were done before the variants were identified. So really the Johnson & Johnson one is also very effective. It reduces your risk of hospitalization, subsequently reducing risk of death. Again, quite effective. But again, it's under the FDA is looking at it, so they'll look at the data more closely and kind of see if they will allow it for emergency use or not. But these 2 are the ones that are available. Again, key things: it reduces your risk of developing 1, COVID-19, 2 is severe COVID-19, and 3 is hospitalization leading to death. So highly efficacious. You kind of think about it in the lines of other vaccines that are kind of available in the community at this point. Like the flu, it's actually probably more effective than just the regular flu vaccine, and kind of comparable to other things. Big question that I received earlier: what's the difference between Pfizer and Moderna? Are there differences? So one thing I'd like to talk about before we just kind of even mention the side effects is that, as with any new medication, the thing that gets publicized and written about in the news is the spotlight on the side effects and how it affects everybody. And these rare events will appear in the news. I mean, the things like the folks that develop like the anaphylaxis and things after the vaccine, those are the things that definitely kind of catch everybody's eye in the news. The task for us here is really to kind of put all these things into in the population that gets vaccine, what are the common side effects. And it's kind of in the category as even like the shingles vaccine or the flu vaccine. The most common side effects are really injection site pain. As you might expect, after getting a vaccine, you're going to have some local soreness. And that's pretty common. And these side effects here are, can you guys still hear me okay? I just got some.
We could hear you. Your video went out, but we could still hear you.
Oh, can you still see the PowerPoint or no?
Yes, we can see you and the PowerPoint now. Yes.
Okay. All right. Okay. I'm not sure what had happened there. So these side effects that are listed here in the graph are really the side effects after the second dose of the vaccine. So after the second dose is actually when there's a higher risk of side effects as compared to the first one. But again, the most common ones within the first 12 to 24 hours, you might get some injection site pain. Then within the first day or second day after the vaccine, you might experience things like muscle aches, maybe some headaches, fatigue, joint pain, fever, chills. Again, all of these kind of really subside after the first couple of days. There is a rare delayed, with the first 5 to 14 days, people might develop a little bit of a rash or warmth or tenderness around the injection site as well too. So really taking acetaminophen or non-steroidals is helpful. But in terms of the differences, so the Pfizer vaccine really looked at people 16 years and older. The Moderna was 18 years and older. There is no age cutoff. So anyone above that age is eligible to get it. There's not a maximum age or anything like that. 2 shots, 21 days between shots for the Pfizer vaccine, 28 days for the Moderna vaccine. And I'll talk about this. There's a little caveat that just came out recently about that. And again, the efficacy that they report is after both doses of the vaccine, okay? There is some hypersensitivity reported. So again, these are kind of, I kind of put this in here as commonly asked questions. So what's the short-term safety? Again, kind of the things we highlighted in the actual trials, there was no report of anaphylaxis, but since it's been rolled out to the general population, again, kind of very small numbers, 21 cases in about almost 1.8 million cases with the Pfizer vaccine, 10 cases of anaphylaxis and about 4 million doses of the Moderna vaccine. As you might expect with any medication or vaccine or anything that rolls out, there is the chance of developing side effects. And so if you're going to get the vaccine, if you've had a prior reaction to any vaccine, you should let your provider know. If it's a specific component of the vaccine, that's something that needs to be talked about more. Just because you've had a reaction to one vaccine in the past does not exclude you from the coronavirus vaccine. You still may be eligible. It's actually about kind of finding out what you were specifically allergic to, what the reaction was, and what the components of the coronavirus vaccine are, aside from the mRNA component, because it is housed in a solute that has some other particles to it as well too. So as I said, nothing really in medicine is 100% safe, but this is pretty darn safe in terms of side effect profile, efficacy, and everything else like that. So the recommendation really from the Parkinson's Foundation, and what I tell folks is, if you're interested, have Parkinson's disease, don't have any of the other kind of contraindications, meaning like immunosuppression, things like that, then you should get the vaccine if you're interested. So with the Pfizer vaccine, when do you get the second dose? So after 21 days, there's kind of a 4-day grace period. Moderna, 28 days, there's a 4-day grace period. This has been extended to about 6 weeks or 42 days at this point. A lot of that has to do with some of the trial data, but also kind of the supply chain in terms of the availability of the vaccine. It's hard to know what happens after 6 weeks between doses, but if you get the first one, try to get the second one within the first 6 weeks or so, okay? One thing that people ask, can I get it if I've just recently had a vaccine. So what the CDC says is wait at least 14 days, if not 28 days after a vaccine. So shingles vaccine, flu vaccine, things of that nature. So that's something important and something to think about. What about if I recently had COVID-19? So the typical recommendation is wait until the acute infection is over, or if you're asymptomatic, wait till your quarantine period is over, so at least 14 days. Some people extend it out to about 3 months or so. There's this thought that after COVID-19 infection, that you develop your own antibodies, and that will help you. But again, as I said in the trial, there were patients that were enrolled that had COVID-19, recovered, and got the vaccine. So it's safe even in that situation. So the recommendation that I say is get both doses, get them on time, get them within the 6 weeks. And then there's those few caveats there. The one thing I would say is that if you've been hospitalized with COVID-19, have received monoclonal antibodies or plasma, then you have to wait at least 90 days after that. But that's a different story that may not apply to most folks here. Another question that came up, how long will the vaccines work? It's a tough question to answer. For the Pfizer vaccine, the median duration, they looked at least 2 months of data, sometimes longer than that. Definitely effective for that period of time. They're doing a lot of follow-up studies, so that information will get published as it comes along. The Moderna study looked at data all the way up to 119 days and looked at antibodies. So there's definitely presence of antibodies to the COVID-19 virus in your system to at least about 119 days. So it does last at least that long. Beyond that, the data is still pending, and that remains to be seen. A lot of the answers to many of these questions really remains to be seen. Do I need both doses? So there is, like I said, there is some protection after the first 10 to 14 days, but it doesn't come close to the second dose. So really get the second dose, pushes you up to the 95%, 94% efficacy rate. So that's important. Long-term safety, again, pending, but if you do get the vaccine, there is a CDC smartphone-based tool. They're doing a follow-up survey, symptoms after the vaccine, things of that nature. So if you can participate in it, that is helpful. Again, a lot of this data collection can be harvested in the future and published, and really give more information about how effective the vaccine is, what side effects people are experiencing, and all that. So that's important if you can do it. Does the vaccine prevent transmission to others? So again, the endpoints for the trials looked at really the things that we talked about: symptomatic cases, severe cases, hospitalizations, deaths. So the data about asymptomatic cases and carriers, it's unknown. But the thing that I would highlight is that in up to 40% of folks that either get identified as having COVID-19 are asymptomatic. And when you're asymptomatic, you're more likely to transmit to other folks because you don't know it. You're around other people. You may be transmitting the coronavirus, and that's how a lot of the community spread occurs. And so that remains a little bit of an unknown. I would say that the Johnson & Johnson recent data suggests that there does seem to be some efficacy for their vaccine for these asymptomatic patients as well too. But in theory, if a lot of people are getting the vaccine, it should reduce transmission rate. But the recommendation still holds to continue wearing your masks, continue social distancing, practice hand hygiene. Again, all these things are still a must despite getting the vaccine, okay? Will the vaccine work against new strains? Kind of delved into this a little bit earlier. Again, the trials enrolled folks before these new strains were identified, such as the Great Britain variant, the South African variant, so forth. So remains to be seen. Moderna just released some newsletter saying that they are looking at whether their vaccine is amenable to the South African variant and so forth. So there should be some information coming out on that. But this shouldn't preclude you from getting the vaccine that is available at the moment. So if you're available, if you want it, I would still get the vaccine. Do I need a booster shot in the future? Remains to be seen. It remains to be seen. The booster shot may be just for the variants. It also may be for increase your antibodies in the future, depending on how long they last in your symptoms. So it's possible that 6 months, a year down the road, they may want us to get a booster shot, or it may become something annual like the influenza vaccine. So again, remains to be seen as far as that. Should patients who have recovered from COVID-19 still get the vaccine? This is a definite yes. As talked about earlier, folks that were in the trial, had COVID-19, recovered, got the vaccine, still showed antibody production and reduction of severe COVID-19 cases and hospitalizations. So the answer to that is yes. Does the vaccine affect evaluation of someone? Let's say you got the vaccine and started having some symptoms that were concerning for COVID-19. And the answer to that is no. You can still get the COVID-19 test, the PCR or antigen testing. The vaccine does not influence the results of that. Should we double mask? So we talked about this earlier. Again, a single mask should be sufficient as long as it's appropriate in size, snug fit, no air leaks or gaps. If you are going to wear double masks, really a surgical mask underneath and then a tight fitting cloth mask over it is helpful. There's no real reason to wear two surgical masks together. A single KN95 or an N95 should be sufficient, as we talked about the size of the particles and all that in the past. Again, avoid bandanas, the gaiters, the scarves, thinly woven cloth masks. So again, multiple layers, tightly woven cloth masks are ideal. Again, if you can shine a light through it and can see the light on the other side, may not be ideal. Are there more serious reactions to vaccine in patients with PD? This is unknown. There's not any separate pooled data for folks that just have Parkinson's disease and got the vaccine. Again, that data will probably be pulled out in the future, but at this point in time, can't answer that specific question. And then this seems to be kind of a hot topic. Does COVID-19 increase your risk of Parkinson's disease? There are 3 case reports published so far, but I would say that the causal relationship of COVID-19 and Parkinson's disease is definitely not robust enough to say that, yes, it does. It actually has been met with a lot of skepticism in our movement disorders community. And these 3 authors, big names in our movement disorders, Parkinson's world, basically said there's not enough supportive, robust evidence for this link at this point in time. Again, it'll still take some time. I know that lack of smell or loss of smell is common in Parkinson's and also COVID-19, but in COVID-19, usually the lack of smell or less smell usually tends to improve as you heal from the COVID-19 as well too. So again, a few published case reports, but really the cause and effect is really kind of iffy at this moment. So I would not hang my hat on that at this point. And then finally, just for COVID-19 vaccine, talk to your local doctor, your primary care doctor, you can look at the DHEC website, the CDC website, your local grocery stores. All these places will have information on if you're interested in getting the vaccine, where to get it, how to sign up for it, and all those things. The most recent one, the change was really folks 65 and older are now allowed to get the vaccine in South Carolina. That's kind of the big things here. So that's the end of my talk. Hopefully it kind of highlighted the things that people wanted to hear about, but I'm open to any questions that have come up in the chat, or feel free to just ask questions.
Thank you. That was so much great information. If you do have a question, and you'll need to unmute yourself before you start talking. Now that we're back, you can kind of see everyone else. Does anybody have something that wasn't covered or something that was in the information that they'd like to ask?
I'd like to ask.
Go ahead.
I'd like to ask a question. Can you hear me?
Yes, we can hear you. Please go ahead with the question.
Thanks, Robin. Go ahead.
Oh, okay, thank you. When you sign up with Walgreens or CVS or your grocery store, wherever you are signing up to get your first dose, they tell you when to come back. And my husband, who has Parkinson's, he came back for his second shot, he came back in less than 21 days. And now I got the first Moderna, and your slide presentation shows 28 days, and they signed me up for 3 weeks. So are we both covered?
Mm-hmm. Yeah, again, it remains the data that I in the slide presentation was from the actual original papers, but that's kind of skewed a little bit. A lot of that is kind of based on availability of the vaccine, but 21 days should be fine for yourself, and your husband should be fine as well too. Yeah, it's really about getting the second dose, which really increases the efficacy rate and the production of the antibodies.
Okay, thank you.
Yes, you're welcome.
I have a question.
Susan, did you have a question?
I do. If just by happenstance you get the Johnson & Johnson once it's approved with a lower efficacy rate, if you are in a risky kind of job situation, should you down the line get either the Moderna or the Pfizer on top of having gotten the Johnson & Johnson early?
Yeah, that is a hard question to answer. There's not really any data on that at this point in time. I did look at the CDC website yesterday about whether the other two vaccines are interchangeable, and the preference is still for you, if you're going to get one vaccine, if it's Pfizer or Moderna, get the second vaccine of the same brand. But for whatever reason you're unable to do it within the 6 weeks or whatnot, the other vaccine it's okay. But I don't know if the Johnson & Johnson vaccine and these two are going to be interchangeable, because it is a different technology. The Johnson & Johnson vaccine is not an mRNA technology. It is delivered through a viral vector. So it's a different way of having your body produce antibodies. So I don't know if that and the two that are available at this point will be interchangeable as the two that are already available.
Okay, thanks for that.
Yeah, you're welcome.
So if I can interject, you said basically you could have the Pfizer, and if you cannot get to the Pfizer because of the circumstances you're in, that you might be able to use the Moderna?
You might be able to. There's not anything that says, at least right now, that's a contraindication at this point, but the preference is still, again, to get both of the same. And most places are making sure that you get both of the same. So.
Hi, this is John. I have a quick question. We've talked or heard in the news quite a bit about herd immunity. Is that the same for Parkinson's patients? Are there any cohort studies? I'm sure it's too early for any kind of studies like that, but what do we know about herd immunity in the Parkinson's community?
That's a good question. Again, we don't have any data on that. The trend towards herd immunity will increase in the general population as more and more people become vaccinated and develop antibodies. But there's not anything specifically about Parkinson's disease and herd immunity at this point. But just anecdotally, I would say that a lot of the folks that I've talked to in clinic with Parkinson's disease so far have either gotten the first vaccine, second vaccine, or scheduled to get it. So a lot of folks are signing up for it. So I think the herd immunity amongst the Parkinson's folks will definitely be there for sure.
I have a question.
Go ahead.
I have a question.
Go ahead, Edith.
If you have rheumatoid arthritis and you're taking biologic Enbrel, which lowers your immunity, is it safe to get the vaccine?
So it's not necessarily a contraindication. But I would definitely talk to your rheumatologist about it if you can get the vaccine. Because a lot of folks that have neurologic diseases are also on immunosuppressive therapy, same as rheumatoid arthritis. And some folks have been getting the vaccine, but that's a question that definitely you should ask the rheumatologist whether it's safe for you to get it. Because again, it's very individual specific.
Okay. Thank you.
You're welcome.
Dr. Virapam, for those of us who are maybe more early onset Parkinson's patients, that means below that 65 line, Is it any indications that we should press with our doctors to try and get in early for an appointment for the vaccine or not?
At this point, good question. Good question. I've been asked this a few times recently. Unfortunately, whether or not you have Parkinson's disease, as long as the age cutoff is not there, you're not going to be able to move up in the line, unfortunately. So really have to wait for the South Carolina DHEC to kind of adjust their guidelines moving forward. And we simply don't have any control over that as a provider. It's really based on the state laws that really govern that. And each state is different, interestingly enough.
I have a quick comment on that. My husband is more early onset too. There's some programs out there right now. I know Walmart in like the Anderson area where you can call Walmart and be on their cancel list. And if someone cancels their appointment at the last minute, they'll call you and you have to basically go there right away. But they don't have the age requirement. It's basically anybody who wants it, because I think it's a use it or it goes bad kind of scenario. So I actually know a handful of people that have already done it, like put their name on the list on one day and got called the next day. So might be something you might want to look into.
Oh, that's good. That's good to know. That's good to know. Yeah, so the use it or lose it is definitely true. So for the Pfizer vaccine, since it's stored at a super low temperature, once they thaw it, it has to be used within like 5 days or so. So it, again, the use it or lose it is definitely true. The Moderna lasts a little bit longer, but that's good to know. It's good to know. I was not aware of that.
If you're on a steroid now because you have the virus and stuff, how long after you're off the steroid and you're considered free that you should go get tested again to see that you're negative and then get the second shot?
That I don't know specifically about steroids. That may be a question for are you seeing a primary care provider or a pulmonologist? Yeah, I would ask them specifically, but typically what they say is resolution, at least, again, there's some gray zone to it, but it's resolution of infection. Sometimes people wait at least 14 days after they've been cleared, or up to 90 days after, then the people sign up for the vaccine. That's what some of the data suggests at this point.
Thank you.
You're welcome.
Well, that's about perfect. It's noon, so
Quick question. Quick question.
Is there one more question? Yes.
Melissa has atypical Parkinson's.
Mm-hmm.
Does that make any difference between the atypical and regular?
Not in terms of getting the vaccine. Still recommended for atypical Parkinsonism. So.
Yeah. Well, we got it anyway, so we were just checking back.
You're welcome. You're welcome. I'm happy to hang around for any other questions too. I don't have any obligations at this time, but so if anybody else has any other questions, I'm happy to hang around.
Dr. Veerpan, for all of our members that have grandchildren, can you speak to how grandchildren or children in general may or may not contribute to them becoming infected with COVID?
Sorry, could you repeat that question again? Sorry, I didn't catch the first part of it.
Yes, for all of our members that have grandchildren, can you speak to how they may or may not be worried about being infected with COVID with their grandchildren?
Yeah. So it's actually an interesting question because if you go to the Parkinson's Foundation website and look at COVID-19, there was actually a recent seminar, a lecture by Dr. Michael Oken, who's the director of the Parkinson's Foundation, and this very question kind of came up about whether it's safe to visit grandchildren and things of that nature. Yes, it's true that COVID-19 may be less in children, but it still is a tough decision, I would say, because, again, with the asymptomatic carrier status, there's still the risk of potentially transmitting the virus to children, and same applies for the converse. So grandchildren transmitting it as well too. So the response is still to wear masks and socially distance, and that's kind of been the standard guidelines from the CDC and the Parkinson's Foundation. Certainly, if you're all living in the same house and know where everyone's been, then it may be more reasonable to kind of be in more close proximity. But if someone's traveling from out of state and you're not sure where they've been or who they've been around, then that's a different situation. So I think still all the same guidelines that everyone has been following in terms of masking and socially distancing and hand hygiene are still all important. And it's a tough question to answer, but there's still the risk. And I've told everybody it's still best to be safe at this point until we know more.
I know that is such a difficult issue for a lot of our members, not being able to hug their grandkids for a while at this point. So
yeah,
definitely a hard answer.
It's tough. It's tough. But yeah. So I would say, on the Parkinson's Foundation website, good lecture there by Dr. Oken as well, if you're interested about the COVID-19 vaccine.
Dr. Hyde, what are your thoughts on pregnant women receiving the vaccine?
So there have been folks that have been getting it that have been pregnant. I've had some colleagues that were pregnant and that have gotten the vaccine. So again, it's a very individual decision, something to discuss with your OBGYN provider, something to discuss with your medical care provider as well too. Because again, not every pregnancy is the same. So there's different risks and different circumstances. So something definitely to talk more closely about it. But yes, anecdotally, I've had some colleagues get the vaccine who have been pregnant. So again, very individual decision, but something that should be delved into very carefully with your medical care team.
No complications that you know of for people who have
not in the couple of people that I've anecdotally known, but again, that's just that's a very small N. It's a N of 2 people. So, but it's again not a contraindication. So it's not an absolute contraindication. Just because you're pregnant, you're not allowed to get the vaccine. You may be allowed to, again, depending on the circumstances and the situation.
Dr. Veerpan, there's a question in the chat. Is it safe to gather with others who have tested positive for COVID antibodies? Potentially. Again, even if you have COVID antibodies, it does not mean that you will not get COVID-19. It reduces your risk of, again, the severe COVID-19 that leads to hospitalization. So you may still get mild COVID-19 or asymptomatic COVID-19. So again, all the trials looked at the kind of the more extreme, the severe cases leading to the hospitalizations. So, so there's still potential risk for getting COVID-19. So still, again, I would still practice all the necessary social precautions as we've been doing.
Dr. Veerpan, did I just hear you say that we could both contract it and spread it? And if so, what's any data tell us about contact tracing still? Here in the upstate, probably most of us are around the same neighbors and things all the time. We probably feel fairly safe, in terms of COVID, but we don't want to let our guards down. But you don't want to be socially, brutal or blunt either, always telling people to step back 6 feet, So it's kind of a hard thing there sometimes, to kind of be, kind to people and at the same time be careful. You want to make sure that the data backs up your decision. To say, like, contact tracing says that, it's coming into our neighborhoods through this method or that way.
Correct. Yeah, it certainly is a tough situation, especially for people you've known for a long time and are friends with and things like that. It still is tough, but I certainly would say that I don't think it's the time to let our guards down at this point, just because the data that I showed earlier with those multiple spikes in the number of daily infections in South Carolina and hospitalizations and all those things. We're just now on the downtrend, and we certainly don't want to see a spike in that. I would say that the mask wearing usage rate in South Carolina has improved. So we're kind of hovering between 70% and 72, 73% of folks are wearing masks consistently. So that's improved. And I think that still has to continue. But I would say to not let the guard down just yet, just because things are improving. We don't want another spike. I mean, we're hoping that things continue to improve with the higher vaccination rates, and the more we learn about the vaccine. And, we're hoping to return to normalcy at some point, but don't want to let our guards down just yet.
And did you say that we could spread as well, even though once you have the vaccine, you can still contract and spread?
It's possible. Correct. Yes. So you could still get COVID-19 despite getting the vaccine. Again, the vaccine reduces your risk significantly of getting COVID-19 as well as being hospitalized with COVID-19. But yes, you can still get COVID-19 and still potentially spread it. And you could potentially still be an asymptomatic carrier. So you may still get COVID-19, not know it, and still transmit it as well too. So those risks are still there. That's really the reason for continued social precautions despite getting the vaccine.
I have one more question.
Yes, ma'am.
Yesterday, I went out and I was wearing an N95 and a cloth mask over it. It was kind of a warm day, and by the time I walked in the store, I was just breathing very heavily, and I felt like I maybe was breathing in more vaccine that way, or the bacteria, if it was present. It concerned me that because of my heavy breathing, I was breathing in more bacteria.
Right. So if you have like baseline respiratory conditions and other things, you have to be careful. I think a single N95, if worn appropriately, is quite effective. And that's what medical providers are wearing in the hospital when they're exposed to folks that have COVID-19 and are actively treating them. And again, that mask in itself should be quite effective. But some people want to take the extra precaution and wear a cloth mask above that. The single, if it's an N95 worn appropriately, still should be should be very, very effective.
Okay, yeah, I wasn't aware that I had a breathing difficulty, but just the exertion that I don't usually do.
I think it's going to be a concern as the weather gets warmer. Now it's nice in the winter, it's been cold and we wear the masks and it's okay. But as it gets warmer, I know that's going to be a risk. So I appreciate all of the comments that you make about that encouragement. I think that's been a big question with people is how much with the vaccine, now what? What does it actually do? What does it prevent? What's our behavior change going to be? So I think all of that was really helpful information, and certainly for us. And I know a lot of the members have asked, at what point are we going to, return to live programming? And so while we have such a big group on, just to let everyone know, really for the first 6 months of the year, we had no intention of doing anything live, and really see where we are as we get toward May and June, and what things look like. And if we can do something safely, certainly outdoors, and with masks, we're eager to be able to see everybody as much as everyone else is. But our goal is to keep everyone safe. So we're glad to have so many on today. Again, Dr. Virapan, I want to thank you for your time. This is recorded, has been recorded. It will be on the website. So you can go back and revisit if you want any more clarification. So again, thank you everyone for being here. And thank you, Dr. Virapan.
Thank you.
Thank you for having me.
Have a wonderful day, everybody.